On this computer. All right, great. We are recording now. So welcome everybody to this webinar. This is the 3 key assessments to facilitate birth. My name is Lynn Schulte. I'm a women's health physical therapist. I work in the Boulder and Denver, Colorado areas, and I'm also the founder of the Institute for Birth Healing. And I'm a mom. I have 2 amazing teenage boys, Austin and Justin. Austin is 19 and studying in college over in China, just outside of Shanghai. And Justin is almost 17 and a junior in high school. So we're currently looking for colleges. My boys are amazing. I absolutely love being a mom. And I also love being a physical therapist. I've been one I stopped counting at 30 years. So I have no idea where I'm actually at. I think right around 30, but I'm not going any higher than that. But I love actually seeing how the course of my career has really led me to be able to apply everything that I know to the pregnant postpartum body. So all the courses that I've taken along the way, from the pelvic mobilizations I learned with Jerry Hesh, and the visceral manipulation courses that I've taken, the craniosacral courses, just all of them, I've been able to apply those skills to the pregnant postpartum body. And I literally have, for the last 10 years, have mainly been seeing pregnant and postpartum women. And what I realized is that there's an actual pattern that the body goes into to get the baby out. And so I kept seeing this pattern show up in all my postpartum moms. And then I figured out how to release that pattern. And moms kept telling me that they were feeling great after one session. And so then I started applying that knowledge to the pregnant body and helping to get moms out of pain during pregnancy, and also helping to prepare her body for birth. And so what I did was I started putting on YouTube some of the things that I was finding in the pregnant postpartum body, and just trying to educate both practitioners and moms to let them know what I'm finding and what's going on for them. And then I started getting emails from people all over the world, from moms all over the world, going, "Oh my God, I have exactly what you're talking about. And do you know someone who can help me?" And because this is something that I've just discovered on my own, it's not from a course that I've taken, I really didn't have anyone to refer them to other than, go try to see a pelvic floor physical therapist, try to see a visceral manipulation person, and see if they can help you out. And that's when I realized that I really needed to get this work out into the world, that I can't see every mom and I don't want to, but I do want to help as many moms as possible. And so I founded the Institute for Birth Healing back in fall of 2016, and I started teaching practitioners what I know about the pregnant and postpartum body. And I've also created a certification process to become certified as a birth healing specialist. And I'm happy to say that we are in the midst of generating our first round of certified birth healing specialists that are just currently getting certified, because I just taught my first advanced course here in North America in December. So they're going through, there's testing and case studies that they need to write up, and there's a whole process for becoming certified. And it is my hope and dream and goal that we will have a certified birth healing specialist in every city in the world. I'm going to keep teaching until that happens, or I die. So that is the goal of the Institute for Birth Healing, is really to support moms in feeling better after birth, and creating practitioners who understand the pregnant postpartum body and have the skills that they need to be able to help them to recover, to prepare for birth, and to recover more completely afterwards. So let's go ahead and dive into what we're going to be talking about tonight. And the thing is, during pregnancy, most practitioners are really focusing on these 2 things, which is the growth of the baby and the health of the mama. And while that's great, we definitely need that, but nobody is really assessing what I call the birth door. We're just assuming that the baby's going to be able to come out. And we're not actually assessing what I call the birth door. And the birth door is your pelvis. The pelvis is like the front door to a house. That's how the baby gets out. And the sacrum there, I'll show you the motions that the sacrum goes into for birth. Sorry, I'm just going to turn off my heater here. The sacrum acts like the hinge to the door, and the pelvic bones actually act like the actual door. And so we're not assessing to see if the door can open. We're just assuming. So we go into birth and we're wondering, is the door going to open? Is baby going to be able to come on out? Sometimes it only opens part way, and these mamas end up in cesarean births. 32% here in the North America, in the US anyway, end up in cesarean births. And my question is, why isn't it opening all the way? And that's what we need for babies to be able to come on out. There's my little doggy. This is my actual front door here. So that's Ashton there. And my question is, why isn't it opening all the way? And there's things that we could be doing to assess, to see if the body has the ability to allow the baby to come on out in the first place. And this is just what's missing in our care today. This is what I think. Midwives, they're just not taught this. OBGYNs, they're not taught this. They're not aware of, they might be aware of the mechanics, but they're not aware of how they can affect the mechanics. And really, luckily for 2/3 of the moms that go into birth and go into labor, it does happen and it does work. My question is, I wonder if it couldn't work easier. Maybe those, 35 to 50 hour labors could be shortened if we had assessed the birth door and fixed any of the mechanical issues that moms bring to her birth in her body. So we're going to be talking about that today. And so to open the birth door, there's 3 key assessments that we need to look at. And the first one is to make sure that baby is in a good position. In order to get baby into a good position, we need good abdominal and uterine tissue mobility. And there's a couple of things that moms can bring to her birth that can inhibit this. And so we really need to be assessing what is the baby's position in the belly. And thank God for Gail Tooley and her work with spinning babies. Absolutely love her website, love her work. And she's really brought this greater awareness of being aware of where is the baby positioned in the belly. And, is the baby's head in midline? We really want that head to be exactly right in the middle by that pubic bone. And a lot of times I find the baby's head, not a lot, but sometimes I'll find the baby's head off into one hip. So it's heading down one groin or into one hip. And it blows my mind to think that we're allowing moms to start labor with that happening. To me, that's the baby's getting pulled off to the side. Why? Why is the baby's head not midline? And there's a couple of things that we need to assess that we'll talk about here. So is the baby headed into one hip? Can the baby inhabit only one side of the mom's belly? Now you can see that in most women, like where the baby is just held off onto one side, but sometimes the mobility is absent and the mom's belly looks pretty round. So it's really my feeling that we need to be assessing not only baby's position, but does the mom's uterus have the mobility to move side to side to allow that baby to get into the best position possible to come out? We also want to know if that baby's breech or not. So we need to be thinking about the tightness in the abdominal fascia and the uterine ligaments. So if we have tightness in the abdominal fascia or the uterine ligaments, that can pull the baby off to one side. But also pelvic floor muscle tension can also repel a baby away. What I find is if a baby's heading into, say, the left hip, the right side pelvic floor muscles tend to be very tight. So we really want to address these 2 issues so baby's head can be midline before we start labor. How much more effort and energy is going to take for that uterus to have to help the baby find that pelvic inlet? So I really wish that every mom going into labor had her belly assessed, those soft tissue ligaments and fascia released prior to going into labor so that baby has the ability to wiggle and get into the best position possible to come on out. So the first key assessment we need to do is that lower abdominal fascia. And there's 2 things that I actually do. I actually see how well I can sink in side to side on either side of those groin areas for that baby, or by the baby, hopefully baby's head. And then I also see mobility wise, can the uterus gently move side to side evenly? And now I'm not shaking it like a water balloon or anything. It's just a gentle, can the uterus move as evenly to one side as it can to the other side? We also need to take into consideration that if the baby's body is more on that left side, that may restrict some of the mobility. But there's other key assessments that we can really look at to see if restrictions in these ligaments in this fascia are creating tension for possibly the baby's inability to come on out, or not inability, but it might just make it harder. So this is the first assessment. So what are some of the things that can restrict abdominal fascia? Appendectomy scar tissue is the #1 reason and issue that we really need to be assessing for moms. I find it 100% of the time. If mom has had an appendectomy at any time in her life, whether it was during her childhood or her adulthood, it inhibits that uterine mobility. You will always find the uterus restricted off to the right-hand side where they took that appendix out. And so that we tend to find babies off to that right-hand side. The baby can't inhabit the left side. It can't wiggle its way over to that left side to find a easier way to come on out. I actually had one mom that came to see me that had an appendectomy, but her belly looked super round and really cute, you know, like just very healthy and nice in midline. But yet when I checked her mobility and her tissue's ability to sink into that right groin and the ability of that uterus to move to the left, it was so restricted. And she was pregnant with her first baby, so she didn't know any different. And once I released it and released that abdominal tissue, she felt so much more relief. I remember now when she came in, she goes, "Oh, I know exactly where my baby is in my belly." And I just thought that was a really curious statement because I've never heard any other mom say that. They're kind of like, I kind of know. But because her uterus was so restricted, I think that's why she had such a good sense of where her baby was. And then once we freed things up in there for her, she felt completely different in her abdomen. And she was actually more comfortable, but she didn't realize that she was uncomfortable in the first place because this was her first pregnancy. So please, we need to be asking our moms if they've had appendectomies at any time during their life prior to going into labor, because if she has, I can almost guarantee you that you're gonna find uterine restriction to the right-hand side. Seatbelt injuries from car accidents can also cause restrictions in that uterine mobility. It doesn't mean any time during their life. If they had a seatbelt injury, that seatbelt goes right across that lower abdomen and can cause scar tissue, can cause bruising in that tissue from being held back during the accident. So we just need to be aware of that and see what's happening with the uterus. This could also be an indication of why mom might be having back pain during pregnancy as well, if they did have this. So any other lower abdominal surgeries is going to create scar tissue, and we just need to address if there's any restrictions from that scar tissue. And then any other injuries to the abdominal area. We could have sports injuries, falls, anything. We just need to be asking moms this prior to her going into labor, and then also assessing this abdominal fascia. All right. Oh, in cesarean section scar tissue, again, we can, I used to think that the cesarean scar tissue gets stretched out because mom's pregnant again, and the act of the uterus growing actually, can free up that scar tissue. But I still find restrictions after they're done being pregnant. So I think that it's important for us to just assess it and see. After birth, I always find cesarean section scars create tension on one side more than the other. So, it would be, I think that we could assume maybe that it might create some restriction in the mobility of those tissues during pregnancy as well. So again, let's just check it out. All right. So Brittany, are there any questions so far?
No questions yet.
No questions yet? Okay, so please feel free to share any questions that you have in the chat box, and we will answer them during these little section breaks, okay? So no questions popping up in there? So we will move on to our second key assessment then. So the first key assessment is the baby being in a good position by releasing any abdominal restrictions or uterine tissue mobility. I'm seeing that there's a question in there. Should we answer that, Brittany? Any thoughts about shoulder dystocia? Yeah, I haven't been at a lot of births, so I can't speak specifically for that. I think Gail Tooley is a better resource for shoulder dystocia. I just wonder if there's restrictions, though, that baby wasn't able to get into the best position possible to come on out, and it creates kind of a jamming going on in there. So, there's so many amazing research opportunities for, pregnancy and birth and things that I can come up with. I just think that we haven't really looked at it close enough to really know. So yeah, I can't really comment on that. All right. Thank you for asking that, though.
We did have another couple questions just come in.
Uh-huh.
So the first is, how soon do you start to do these mobilizations into their pregnancy?
Okay, great. Good question. I never, ever, ever do anything in that first trimester. We just want to let that baby keep growing. There's too many miscarriages that can happen in that first trimester, and we don't want to be blamed as a potential cause for that happening. So I really don't do anything in that first trimester. Try not to. If I do anything because mom's having back pain or pelvic pain or something, it's very energetic. It's not physical at all. So it would depend on what mom's complaining of. If mom's not having any pain and we just want to assess this out, I really would want to take a look at it before that 36-week time frame, because that's when we want baby's head to be down and engaged into the pelvis, is by 36 weeks. So I would want to assess it prior to that to make sure that there isn't any restrictions happening that might be preventing that. Late second, early third trimester would be a great time to assess this stuff. But if mom is having pain, back pains, pelvic pains, then, I assess this all when they come in to see me. So there's no real, limitation on, we can do it as soon as that uterus gets big. I would wait till at least 20 weeks before I start mobilizing anything. And I work more energetically before then. But after that, sometimes that the baby in that uterus getting out of that pelvis can start causing some of that back pain, and we really need to release that. That uterosacral ligament is huge, 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 huge. And while I mentioned Gail Tully's work with spinning babies, and I think it's amazing, sometimes the tissue in the body still needs fascial release. The exercises aren't enough sometimes. And so that's why I think that we should really be assessing these moms prior to birth and helping to release the tissues, because sometimes the stretching isn't enough. So what's the next question, Brittany?
Have you been able to identify daily movements that are inhibiting or facilitating the mobility of the pelvis and uterus?
So wait, inhibiting or facilitating, is that the question?
Yep, so daily movements that either inhibit or facilitate mobility.
Absolutely. Sitting sitting is one of the biggest, and sitting on that tailbone is the absolute worst, especially if mom's sitting cockeyed, with their legs crossed and more pressure on one side. That asymmetrical sitting on the pelvis with the laxity in the ligaments just causes the pelvis to just kind of get cattywampus in there. And that sitting on that tailbone, pushing that forward, is limiting that outlet. And we'll talk about that more in this next key assessment, okay? But that, and so squatting is one of the biggest things that I love to promote for my moms, is sticking that butt out, getting that butt back there and helping to lift that sacrum up so that that tailbone is lifting away from the pubic bone. That's what we need for birth. So those are I would say that is number one, the biggest thing, is the way we're sitting and not walking enough. We're not mobilizing the pelvis enough. Did that answer that question?
Yeah, I think that did. Okay. And then the last question was, do cesarean scars make the next birth difficult because of the restrictions? And then they noted about some mothers failing to progress during labor.
So what really does stop the birth, I think, is the blocked energy from that first birth. So when a baby is trying to come out the pelvis, there's a flow of energy. The birth energy needs to flow out the pelvis. And when a baby is born via cesarean section, that birth energy flow gets stuck and it stops. And so there's this stuck energy that is in the pelvis. Now, it may have been there prior to her being pregnant, and maybe that is part of why that baby wasn't able to fully come on out. We don't really know unless we've worked with these moms prior to her going into labor. And so that's probably one of the biggest keys, is that stuck energy that is really preventing that baby from dropping down and engaging into that pelvic space. As far as like mobility of tissue, there is tightness, but that uterus is growing big. And I used to think that that alone kind of stretches out that scar tissue. But after that next birth, and if the next birth is born via VBAC, I still find restrictions abdominally in that lower abdominal area after that second birth. So it's hard to say. I can't say that cesarean sections really cause a lack of mobility to the uterus as I do with appendectomies. Okay, appendectomies for sure, 100%. C-sections, not so much. But I do see a blockage of energy flow in these women that have had cesarean births. And that's huge. The flow of energy, we want moms to be able to allow that energy to flow down and out the pelvis, down their legs. And too many women, they're just cut off and they're being held. This is before I really even got into this, but my neighbor was pregnant and she was past her due date, and we were just standing out on her front lawn talking. And I'm like, do you mind if I just kind of feel into this, feel into your belly? And she's like, sure. And I'm like, oh, well, your energy is not flowing down your legs here. And I just had her breathe into my hand, and we just kind of worked on opening that flow. She went into labor that next day. So I really do find that a lot, that lack of energy flow is key for birth as well. So any other ones, Brittany?
Nope, those are all the questions for now.
Great, thank you. All right, so let's jump into the second key assessment, and that is good mobility in the pelvis. So look at these pictures of the pelvises here, and these are all the directions that the pelvis needs to move in order to get a baby through the birth door. So in this top picture here, we can see that the ilial bones actually splay out to the side. The sacral base at the top here moves backwards. The tailbone comes forward. The pubic bones widen a little bit, and all those motions actually increase this pelvic inlet. Then once the baby's head hits the pelvic floor muscles, that's a signal to the pelvis that they need to go the opposite direction. So now the ilial bones come in, the ischial bones splay out to the side, the tailbone starts moving backwards, and the sacral base moves forward. This helps open up the pelvic outlet. Now, look at all those motions, those bones have to move. And the sacrum is the hinge. It's the pivot point that allows this opening to get bigger in the inlet and bigger in the outlet. So if the sacroiliac joint is not able to move freely, it's going to inhibit or make birth harder. I'm not saying that any of this is going to stop a baby from coming on out. I'm just saying this is what needs to happen for birth, and if it can't happen easily, it's probably going to make it more challenging for the baby's journey through the pelvis. And so any traumas, any injuries to these bones can inhibit these motions. So if we have a mom here, like I was talking earlier, who is sitting, we tend to sit on this lower third of the sacrum when we're in that slouched position. We drive in that position, we sit on the couch in this position, and all the pressure is right here in this lower third of the sacrum, and it's pushing it forward. And then we're told to do a ton of Kegels, which actually we're going to talk about soon here, but that even shortens this outlet even more. And now it's even more work for the baby to push that backwards to get it to open up. Okay, so can you see that we need to get our moms off of these tailbones? We need to get them off of that lower third of that sacrum so that it can lift backwards and allow that baby to come on out. So traumas and injuries to the pelvis and to these pelvic bones can inhibit these bones from being able to move as easily as possible. I had one mom that I worked with that she was in the ocean and she hyperextended, a wave hit her and she hyperextended her knee and jammed it into the ocean floor. And that jamming imparted all the way up into her left SI joint. And actually her whole left side of her sacrum was super, super hard. And her first birth ended in a cesarean. And so she came to see me throughout her entire second pregnancy just to kind of work on getting her bones to stay released and get them moving again. And then she was able to have a successful VBAC. But my gut just tells me, had she not had that work done, her pelvis wouldn't have been able to open for birth. And this is just not something that we are checking out. Nobody is really assessing these pelvic bones except for my practitioners that are coming to my trainings. And so I would love to teach you how to really assess these bones so that they can, so that we can at least know that they can move in these directions to be able to open up for birth. Now, there's a difference between normal bone and hard bone. By hard bone, I mean that's bone that's been impacted in some way. And I started to feel this in all my postpartum mamas, this left side pubic bone and pubic rami was really hard after birth. Not the left side, the right side. The left side was really, really hard. And then I started to feel how this lower third of the sacrum really felt hard, hard, hard. And then I could also feel it in tailbones when the tailbone got really, really hard. Those are impact traumas. Those are the moms that, if I slide my hand underneath their sacrum and it's hard in there, I'll ask them, have you ever fallen on your tailbone? And 9 times out of 10, they say, yes, I have. And so that's the hardness of the bone that I'm talking about. Bone is actually meant to be spongy. If you look at the matrix on the inside of a bone, it looks like a sponge. And so we want that bone to have a little bit of give to it. Hard bone has no give to it. And so the hardened bone then activates everything that attaches to it. So the muscles get tighter, the fascia, the tendons, everything gets activated, and then it can't open up like it needs to. And it just makes the whole process harder. So I'm not saying that, falls on your tailbone or fractured tailbones are going to inhibit your birth. I'm just wondering if they don't make it a little harder. Okay. So, this is something that, I had one gal came to see me who was, she had a cesarean for her first birth and she really wanted to do a VBAC. And when I went inside to assess her, her tailbone was sticking straight up. Instead of being nice and flat like it is here, it was sticking straight up into this pelvic outlet. And I'm like, well, no wonder you ended up having a cesarean birth. It was a roadblock. It stopped the baby. The baby's head was hitting that tailbone and it was not moving. And so these are the assessments that I really wish that every mom before they go into labor would have so that we just would help her to have an easier birth. So we really want to make sure that the bone has a nice springy quality to it, to not only the bone, but the joint and the tissues that attach to it. And that will allow it to have a greater ability to move. And then it supports the weight without pain. You can see this pelvic bone here is a circle of bone. It's like a ring of bone. And that ring of bone is actually meant to distribute forces throughout it evenly. But when we've had trauma and impact and that bone gets hard, that bone can't distribute the forces evenly, and then the joints end up taking up more pressure. So what I find with symphysis pubis dysfunction is that moms can have a natural hypermobility that causes that symphysis pubis joint to be hypermobile, but she could also have a dysfunction somewhere in that ring of bone. And when we free up that ring of bone, that pain in that symphysis pubis joint can go away. So those are some of the things that I would like to help moms be assessed prior to going into labor so that we can just help her to have an easier time allowing that baby to come on through. So what are some of the causes of dysfunctions in the pelvis? Any falls onto the tailbone or buttocks, injuries from sporting activities. Boy, our ice skaters, ice hockey players. I had a woman who played ice hockey as a kid. Her pelvis was a mess, so hard in so many places. Horseback riders, they tend to fall off their horses a lot, and snowboarders, skiers. So those four tend to be the biggest ones that I see. I'm sure there's others, but if you know that your mom's had a history, she was an ice skater as a kid, man, we really need to be checking out her pelvis to make sure that those bones can move and do what they need to for birth. Now, hypermobility of the joints is kind of the opposite end of this spectrum of what I'm talking about here, but that creates just as much pain during the pregnancy itself. It doesn't cause problems with the birth because these moms that have hypermobility tend to have easier births because their pelvis is able to open up easier. But what we want to help moms with hypermobility is to be able to handle the pregnancy and get through the pregnancy with as minimal discomfort as possible. And so, like I was saying earlier, the hypermobility of the joints can come from true joint hypermobility. And in my pregnancy course, I teach you the different assessments to see if a mom is hypermobile. So that's one thing that can cause it. But we can also have symphysis pubis pain from actually the birth trauma that's happened in a previous birth. So moms bring a lot of trauma into their body from a previous birth, and their next pregnancy is not as comfortable. And when a mom had no pain, no pelvic pain in the first pregnancy, ended up giving birth and now is pregnant with her second one and is having a ton of pelvic pain with her second pregnancy, super clear sign that the pelvic pain is from the birth, and that when we release the birth pattern from the pelvis, we can get her out of pain. And I'm talking in one session when you know what to look for and you know what mobilizations to do to help clear the pelvis of the birth pattern. So car accidents, slamming on brake, that jams up that SI joint. Previous back injuries, that can cause problems. Lower extremity injuries can definitely cause problems that end up into the pelvis. And like I was saying, their previous birth traumas. So those are all things that can cause dysfunctions of the pelvis. And, this is what a mom brings to her pregnancy. This is what a mom brings to her labor. And if we're not assessing these things and we're not aware of what she's bringing to her labor, we're doing her a disservice, in my opinion, because I want moms to have as smooth of a birth as possible. And if we can address these issues prior to her going into labor, it's not going to stop the pain. It's not going to stop the baby from coming out. But maybe by doing these assessments and getting the body assessed and released prior to birth, maybe we're taking her 50-hour labor down to 22. Okay? That's huge. So these are some of the things that I think that can really help moms shorten their labor. So these are all the different techniques that I would love to teach you in my pregnancy course that you can apply toward the pregnant mama. There's over 30 labs in that pregnancy course. 30 different techniques that you will walk away from that you can not only apply to your pregnant moms, but these are great for any client. And so there's a ton to talk about. And one of my big goals is really to help prevent this. This is a complete separation of that symphysis pubis joint. So the ligaments have been disrupted. There is zero stability here. This is a standing stork x-ray that was taken with a mom standing and one knee lifted. And you can see what happens to this joint. There's no integrity here. And this is a surgical issue. There's nothing that we can do as therapists to replace that ligamentous integrity. We can help get them out of pain. I worked with this mama. She had a 9mm separation after birth. When I saw her, she was down to 5mm. I got her out of pain because I got her out of that birth pattern and helped bring her bones into a better alignment. but there was still no stability. And so she did end up having surgery, and I lost contact with her because they moved out of the area, and I tried reaching out to her and I never heard back. So I don't know how that surgery went for her. Surgery of that symphysis pubis joint is not great because they completely fuse it, and that symphysis pubis joint needs a little bit of give. And if it can't give, it's going to cause problems elsewhere. So it's, you know, something that we just want to help avoid in these mamas. And I think if we could assess this pelvic mobility, we can really help moms avoid this. So what questions are there, Brittany?
Just one right now, and it is, does a baby sitting in an OP position affect the ability of the pelvis to move during labor?
Sitting in an OP, yeah, so it can, depending on how far in that baby's head is. So if babies are in an OP position, then we need to help them see if we can help get that baby's head out a bit and see if it can re-engage. And that's where Gail Tooley's inversions are really great. In my birthing course, in my pregnancy course, I do teach how to help mobilize the abdominal tissues in that inversion position. So the inversion helps the baby's head to disengage from the pelvis, so hopefully it can re-engage in a better position. So I think did that answer that? All right. And I'm kind of looking. Okay, is there any else?
No.
Okay, all right, great. Super, so we're gonna move on. So the first key assessment was baby in a good position with good abdominal and uterine tissue mobility. The second one is good mobility in the pelvis. And the third is good flexibility of the pelvic floor muscles. This is huge. These are your pelvic floor muscles. And here's your bones. So the pubic bone is up top here. This is ischium, and tailbone back here. So do you see these muscles here? These are your levator ani muscles on either side. This is your coccygeus muscle. These muscles, I feel, are the most important for birth because they're the ones that allow that pelvis to open up. It allows the sacrum to lift backwards, and it also allows these ischial bones to move out to the side, to splay open to allow the baby to come on out. And the problem is that we have too many childbirth educators telling women that they need to be doing thousands of Kegels a day. And if you can see here on my screen, this is a pelvis, a flexible pelvis. And so if the pelvic floor muscles are my hands here and the tailbone here, and we do tighter, 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 and keep tightening and tightening and tightening, that just closes down the outlet. And then the pelvic floor muscles just get really, really tight. And that doesn't help when we're trying to get the sacrum to move backwards and those pelvic floor muscles to lengthen. And so instead of subscribing that women do thousands of Kegels, I would recommend actually that women massage and check out their pelvic floor muscles prior to going into birth. And I really would love to see the notion of perineal massage change to pelvic floor muscle massage, because I feel like perineal massage, women are so worried about the skin right in here. This is that vaginal opening, and they're just worried about stretching this skin right here. But that's not the issue. The issue are these levator ani muscles down deep. And so for me, it's reaching down in deep and pressing out to the side. Oops, didn't mean to click on that. And clicking and pressing down onto this side and making sure that those muscles have a nice springy bounce to them, like you're pushing down on a trampoline. This is what we need for birth. Too many women are walking around with tension and tone in these pelvic floor muscles, and so that closes down the pelvic outlet already. And then if we tell them that they need to be tightening and tightening and doing all these Kegels, we're just making a problem worse. And I really feel like the pelvic floor muscles are like a stoplight for birth. That if we have too much tension in these pelvic floor muscles, it keeps the baby from engaging and dropping into the pelvis. So if a mom is at 40 weeks gestation and that baby is not dropping into the pelvis, we need to be looking at pelvic floor muscle tension. We also need to look energetically and see if that flow is happening and we're inviting that baby down through that pelvis. And these are all things that I'd love to show you how to do in my pregnancy course. I do feel that we should be checking out the pelvic floor muscles prior to birth. Look at these motions. Again, this is what happens for the baby to get out. The tailbone needs to lift backwards. The sit bones need to move out to the side. The pelvic floor muscles attach right in here. And if they're tight, then that's not going to allow that to open up evenly. And what I have found is that sometimes one ischium splays out way more than the other one. And that's probably because the side that didn't move had too much tone in that pelvic floor muscle. So those bones couldn't open up. So the other side had to open up for the baby to get on through. And that's what we need to help shift and change prior to a woman going into labor. We need to help her to become aware of how to relax these pelvic floor muscles. We need her connected in, and we need to make sure that those pelvic floor muscles have even tone so that those bones have the ability to open up evenly to allow that baby to come in through the midline. And so I started teaching this back in 2016 to some midwives who were coming to my courses. And I've heard from a couple of them that when a labor stalls, they go in and they release the pelvic floor muscles and they say the baby comes right on out. I also had a labor nurse who, before she met me, she just intuitively knew to get in there and try to massage those pelvic floor muscles and help them to relax. She said the doctors loved when she labored a woman because they never ended up in a cesarean birth. And it just goes to prove my point that these pelvic floor muscles are they're magnets. If they're nice and springy and soft, and they'll allow and engage and invite that baby on through. If there's tension on one side, it's going to make it a lot harder for that baby to come on through. So as practitioners, let me talk about this first. So the sacrotuberous ligament here, it attaches into that corner, the ILA of the sacrum down here, and attaches into the ischium. And then the sacrospinous process is right below that. These two ligaments really need to be balanced in order for that sacrum to be able to lift evenly. And so this is an assessment that we should be checking out in our moms prior to birth. And I don't actually treat this ligament directly. I treat it indirectly by treating the bones and mobilizing the bones, and that tends to balance out this ligament. And so again, this is something I would love to teach you in my pregnancy course on how to do this and how to balance it out and how to make sure that mom's pelvis can open up evenly so baby has a smoother, even passage through. But look at this. So this is the external view of this ligament, but look what we see on the inside here. So this is the tailbone back here. So this is the inside view of that. On the inside here is the coccygeus muscle that runs in that same direction as the sacrotuberous ligament on the outside. So not only is it important for us to check out the ligaments and the bones, but we really need to be assessing these muscles internally to make sure that they're released in order to be able to help moms pelvises open up for the baby to come on out. Now, this coccygeus muscle is not a muscle that moms can reach on their own. It is too far deep inside, and I'm talking, we can assess this externally by finding the tailbone and going on either side of the tailbone here. You can press in and feel if that coccygeus is even side to side. And I do have a special way of releasing this muscle that is very gentle and very effective, and it doesn't require a lot of pain and a lot of effort on your part as a practitioner. And we can just help get more balance in there. So I do teach one internal lab during my pregnancy course for those that can do it. If you can't do it, then I do teach you external techniques that you can do. But it's just my feeling. So here we can palpate the muscles externally and assess side to side and make sure that they're nice and even. And there's techniques that we can do to release those muscles if we do find tension more on one side than the other. But it's my feeling that as practitioners, if midwives, if OBs are going in there, labor nurses, if you're going in and checking the cervix anyway, why are we not just turning our finger around and checking to make sure the pelvic floor muscles are in a proper tension, have good mobility, and release that prior to labor too? Okay, so that's what I want to talk about. I really wish, and we can instruct our moms to insert their finger or thumb. I really think the thumb is the easiest way to access our pelvic floor muscles. And I really encourage moms to check their muscles, not so much the perineum. I feel that if the muscles give, the skin will follow. If the muscles don't give, then the skin tears. That's just my theory. It makes sense to me. But I want the focus to not be so much on that perineal body, but on the actual pelvic floor muscles. So I want to start changing it to pelvic floor muscle massage prior to birth. So any questions on the pelvic floor muscles, Brittany?
There are no more questions.
No more questions. Okay, so feel free to ask any if they come.
We just had one come in.
Sure.
They asked, do you ever instruct with a TheraWand?
You know, I haven't. I just haven't. To me, it's kind of a disconnect. Maybe it works well for some people. I personally don't use it in my practice because I want moms to connect in, and I think there's a lot that can happen through the touch. So I don't use the TheraWands because I think it's I just don't like them. But if they work, they can work great for some people. So I'm not dissing them. I just say I personally don't use them myself. Okay. Anything else?
Nope, that's it for right now.
Okay, great. So those are the 3 key assessments: the abdomen, the pelvis, and the pelvic floor muscles. And those are all things that I would love to help you to learn how to do in one of my courses. So I do offer, the Institute for Birth Healing offers 2 sets of courses. We offer courses for body workers and then for birth professionals who are non-hands-on birth professionals. So I have a Facilitate a Smoother Birth and a Faster Recovery. It's a 1-day course that is perfect for doulas, midwives, anybody who can't do body work, okay? And then I also have my Holistic Treatment of the Pregnant Body course and my Holistic Treatment of the Postpartum Body course. Those are both 3-day courses. And then there's also an advanced postpartum body course that is a 4-day course. And that advanced course goes more into the energetics and healing of trauma and emotions and things like that. So my next Facilitating a Smoother Birth and Faster Recovery course is happening down in Fort Lauderdale, Florida, February 18th. It's a Monday. It's President's Day. So if you are in that area, if you want to come to that area, Florida's a fabulous place to be in the wintertime. We would love to have you join us. You can find all of these courses on my website. I'm also teaching my Holistic Treatment of the Pregnant Body in Florida, Fort Lauderdale, that same weekend. I'm also teaching it in Longmont in March and then Portland in May. So I would love, love, love to have each and every one of you come learn this information. It is so effective. The feedback I get from the practitioners who come, they say that they use these techniques on every single person that they work on, men and women. It's really about the pelvis, so anybody with low back, sacral issues, SI joint, they're just super, super effective. And it is actually it's a different way of approaching the body. Instead of imparting what we think should happen on the body, we actually learn to tune into the body and to see where the body draws us and where it pulls us in to see where it wants help. And so it's a little different, but super, super effective. So please, you can go to the instituteforbirthhealing.com/course, and that is where all of my courses are listed for the year. Again, Amanda and I are working on trying to get that LA one confirmed. I'm also trying to get out to the New York area to teach my postpartum course. So I would love to show you that. So I'm going to go ahead and stop the share there. Brittany just, let's see, is there anything? When do you start to do pelvic floor massages? Do you wait until the doctor starts to do their internal evaluation? You know what? If moms are having, as a practitioner on my pregnant mamas, I try to wait till the very end. But if they're having back pain, pelvic pain, and I feel like the pelvic floor muscles are a part of it, I don't do anything in the first trimester at all. Never, ever, ever. if they're having pain, I have done internal work throughout the entire pregnancy with some moms. But if they're not having pain and we just want to kind of assess the pelvic floor muscles, then I try to wait till around that 38 week. That way, we know baby's fully developed and, it's fine. If mom's having intercourse is way more challenging to the cervix, to the uterus, to everything in that area than what I'm doing with those pelvic floor muscles. So I have just seen how important it is to get those muscles to relax and get moms connected to those pelvic floor muscles so they can learn how to relax them during birth. That's really key. So that's how I approach doing my internal work. I try not to do it until the very end unless mom's in pain. Okay. So yeah, Justine is saying it's very helpful for men and women. Definitely. So thanks, Justine, for that. Great. So there, Brittany put in there the link to the courses, so you guys can click on that and see where else we'll be teaching this year. And would just love to have you join in and learn this material because it is so impactful and so helpful for moms. And now I'm not here saying that if we do these 3 key assessments that we're going to stop all C-sections. That's not the case. And I'm not saying that. I've had many women where I've done an assessment and I'm like, in my notes, it's like, yep, ready for birth. They still end up in a cesarean. So there's a lot that goes into getting a baby out, and there's emotional and there's energetic and there's all situations that come up. Baby can turn a different way as they're coming on out, even though we have them in a good position. So there's just no guarantees with birth, but I just like moms to feel that they've set themselves up for as great a success as they can for birth. So yes, massage therapists are great to come to the 3-day course. I have this is my first year where I've actually divided my postpartum course into an internal and external. The postpartum course, there's a lot more internal at labs. The pregnancy course, I don't divide up because there's only one internal lab. And I'm okay if you're willing to come in and learn it, but I just have you sign a waiver that you're only going to practice within your scope of practice, okay? So my pregnancy course does not separate them out, but my postpartum course, I have a 2-day for chiropractors and massage therapists that can't do internal work, and the postpartum, then there's a 3-day course for those that can do internal work. And so the course that is appropriate for a doula and also yoga instructor is the 1-day course. So that's facilitating a smoother birth and a faster recovery. And that we talk about what needs to happen for birth, how we can help moms prepare their bodies better for birth. We also talk about some certain techniques. Everybody does those hip squeezes during pregnancy or during labor, but it's really important for you to know where exactly on the pelvis you should be squeezing to help facilitate the opening of the birth. Remember how much this pelvis has to go this way first and then this way? Well, if you're pushing on the pelvis and it's closing this way when the baby's there and needs to open up, you could be inhibiting things. So in my course, I teach you exactly where to push on the pelvis to help open it up for your mom. So it's an excellent course for doulas, that 1-day facilitating a smoother birth and a faster recovery course. And then we also talk a lot about the postpartum period and ways that you can help facilitate mom in having a faster recovery and helping her to understand what needs to happen in her body. So that course is actually also great for moms too. I've had a couple of moms come to the course and they really enjoyed the information. So anybody is open to come to that course. It doesn't matter if they're a birth professional or not. If you're interested in it, you can come. The other courses though do require that you have the license to do body work and to touch people. All right. So great. I'm trying to think if there's any other questions that I've had in the past. So for whom is the 3-day external course appropriate for? Oh, she got my answer. Okay. Yeah. Massage therapists, chiropractors, anybody who's not able to do the internal work. Boy, I really wish we could change that. I would love to see more people doing internal work. It's just so needed. It's needed to be done in the right way. And I know I'm biased, but I know that my way is really effective in getting the greatest amount of change in the pelvic floor muscles with the least amount of pain, and the greatest amount of respect for that whole area. So I teach a lot of pelvic mobilizations. In fact, I teach you how to mobilize the pelvis while you're doing internal work, and that allows the muscles to just kind of melt. And there's actually a hierarchy to the body that I've learned, that we need to address nervous system, we need to address organs, then the bones, then the fascia, then the muscles. And so when you address the body in that order, it's easier for the muscles to let go. We don't just go in there and hammer and try to get that muscle to release. There's a reason it's tight. We need to listen into the body and help it to understand why it's tight in the first place. So great. Are there any other questions? Great. Well, thank you all so much for coming and being a part of this. I really appreciate your time, and please share this with anybody you know. I really want to get the work out into the world, into other practitioners' hands, so that they can help assist moms in having, smoother births and faster recoveries. So, Julie, I don't know if you had a question there. I just see yes. So, please feel free to type away. I'll stay on and answer any other questions you guys might have. But yeah, these are 3 areas of the body that I just feel that we're not fully addressing. And I think if we started doing it, I think my goal would be, let's try to decrease that cesarean section rate in our countries and help moms have smoother births and less hours birthing. And again, my courses do address both the energetic and the physical, and I feel like we get a more complete healing in that way by addressing all levels. So we'll teach you how to do that if you come to one of the classes or one of the courses. So so we will be sending out a recording of this after we're done here. So anybody who wasn't able to make it can listen into this. And it will also be posted on YouTube as well. So if you know anybody that didn't sign up for the webinar and would like this information, it is on my YouTube channel, Institute for Birth Healing Community. And I also have a Facebook group. If you haven't already joined it, it's the Institute for Birth Healing Community. It is a private Facebook group. You need to ask to join. And it's an amazing, amazing active group of both practitioners and moms. And it's a great way to get questions answered if you have anything, or finding practitioners. Our whole goal is to help moms get, Brittany put in the link to the Facebook group, thank you, Brittany, in the chat section. So you can click on that and ask to join. And we would love to help add you to our community and support you in either supporting moms to be more successful in birth, or supporting yourself in having a more complete, smoother birth and a more complete recovery. So great. Are there any, oh, thank you. Yes. So currently, as of right now, there's only in-person courses, but I am in the process of getting both my pregnancy course and my postpartum course put online. And my goal is to have it done by my next Birth Healing Summit, April 9th. So as of April, both of them will be online. However, if you're wanting to become certified as a birth healing specialist, you need to take one of the basic courses live in person. So and I would suggest the postpartum one. So if you take the postpartum one live, you can take the pregnancy one online and learn that information that way. But yes, in April, I hope to have both the pregnancy and postpartum courses online, and you can purchase and take them that way. All right. Okay. So that is it. So our Facebook community, and also the next Birth Healing Summit is going to be starting April 8th, and it will be for practitioners. We're focused on talking to practitioners, and I have an amazing lineup of people on board, and we've already started doing the interviews. So it's going to be another amazing, amazing event. So I really hope that you'll join us for that as well. Okay? Great. Well, I think we are done. If there's no other questions, we're going to go ahead and sign off and stop the recording. So thank you, everybody, for, do you know when I'm coming to New York? No, I don't, because I haven't found a host yet. So if you know of anybody that's willing to host a 3-day course, I want to bring the postpartum course up to New York. I'm talking to someone in Ithaca right now, but we haven't confirmed anything yet. So if you know of anyone, please listen in, or please let me know. Okay, reach out to me. Lynn at instituteforbirthhealing.com is my email, and I'd love to talk to you about bringing my courses to your area, even if we would have to look. New York, I'm still trying to plan for this year, but any others we can look at 2020 and see where we can go there. Okay? Thanks so much, everybody, for being here, and we'll talk to you next time. Bye-bye.